only in bad light. I love. That's very responsible. January.
Good morning, everyone. Can you hear me?
Yes, we can hear you, ma.
Yes, we can hear you and Dr. Adiadi too.
Thank you so much for joining. You're welcome, Dr. Ejimbe. You're welcome, Dr. Izenwa Konobi. You're welcome, Dr. Abdul Qadri. You're welcome, Dr. Kenneth. You're all welcome to today's session. Please, if you are on this call, kindly introduce yourself in the chat box. Let's get to know each other. I am Dr. Kombi Bolande. I work for Livestock Management Service. And today we are going to be having an interactive session on diagnosis made easy, guide to haematology and biochemistry tests, interpretation in small animals. And we're going to be having this wonderful section by Dr. Ablatif Ajadi. I believe he's already on this call. I'm going to introduce you briefly to Dr. Ajadi. After he's done with his presentation, Dr. Izenwa Konobi is going to help us to have a great participatory discussion. We'll have good question and answer, and Dr. Bala Mohammed is going to come back to give us announcements and also vote of thanks. If you're excited to be in this session, please kindly drop your favorite emoji in the chat box. Thank you. Okay, so news reaching me right now is that a Zoetis personnel will be joining us from Abaxis. It's going to be joining us from Uganda, and it's going to also share some insights on how to use some of these diagnostic tools and better ways, and how we can also get them at affordable prices, which is very accessible to every one of us here in Nigeria. So I'm just going to give you a brief introduction about our can everyone still see my screen? About our speaker. I'm going to give you a brief on Dr. Ajadi. I'd like you to know who he is, what he does, and how it can really give us better things to know about.
I can't hear you again. Dr. Akombi, I can't hear you. Can you hear me? Hello?
I guess she has network issues.
Oh, thank you, my Oga.
Can everyone hear me?
Yes, we can hear you now.
Okay, so I would like to call on Dr. Wakonobi to just introduce us into the session while I introduce the speaker.
Okay. Good morning, everybody.
Morning,
Can you
sir.
hear me?
We can hear you, sir.
Okay. My name is Cesar Konobi, and I technically support the CEO of LMS, and this is about the third in the series of lectures that we have been organizing under Qatar, connecting town to town, that is being organized by LMS. I welcome all of you here, and it is important that we keep reminding ourselves, and through that, telling others, letting others know that you cannot do well in clinical services, whether veterinary or human, without laboratory component. A good, as one of my professors told me over 20 years ago, almost, yeah, 30 years ago, that if one is able to diagnose correctly a case, he's more than 80% done with the management of that case. So the moderator of this program is a young lady, very vibrant, that some of you are already used to, Dr. Awa Akombi. Is a part of the Kotok team, a part of the LMS team, and she's going to introduce the speaker, and she's going to moderate this meeting. Over to you, Awa.
Okay, thank you so much, Dr. Wakunobi. Dr. Ajadi is a DVM graduate of University of Ibadan and currently the Deputy Dean of the Faculty of Veterinary Medicine, University of Ilorin. He's a lecturer in the Department of Veterinary Pathology, where he has been conducting research and teaching students. He obtained a certificate in the basic leadership training and is also a graduate of Nigerian Institute of Management. Dr. Ajadi has served as Sub-Ed Clinical Pathology Unit VTH, Departmental Examination Officer, member of Savannah Veterinary Journal, Faculty Library and Publication Committee, University Committee on Illegal Use of Drug and Substances. I believe that his research interest covers areas of clinical, diagnostic, and molecular pathology and agriculture, makes him very credible and reliable to teach us what he knows about diagnosis. So over to you, Dr. Ajadi.
Thank you very much, Dr. Akombi. It's my honor to be here once again, and as a sequel to the last presentation, I want to welcome us all again to this presentation. And as the moderator rightly said, I'll be interacting with us this morning on the topic Diagnosis Made Easy, a guide to haematology and biochemistry test interpretation in small animals. So without much ado, I will go ahead with the slide, but it's, please, Dr. Akombi, you can help me share the slide. The beauty of every practice and the pride of every practitioner is to have high rates of successful treatments and seamless surgeries. However, it is important to note that there cannot be effective treatment without laboratory investigation. I mean, there cannot be effective treatment without proper diagnosis. And an evidence-based diagnosis cannot be made without proper laboratory investigation. Meanwhile, laboratory investigation is worthless without meaningful interpretation. And that is what has brought us together this morning to interact with one another. Please, next slide. It is pertinent to remind us the essence of hematology and biochemistry as part of analysis in laboratory investigation. And the essential ones are the ones listed here. Hematology and biochemical analysis are very vital for the evaluation of patients that has been slated for surgery. It is also useful in monitoring the progress of disease. You can also use hematology and biochemical analysis to quantify the level of abnormality in a diseased patient. It can also be used to aid disease diagnosis. It can as well be employed to confirm diagnosis after other conditions have been met. Another important thing about hematology and biochemical analysis is that it also helps us in transfusion of blood. And when proper diagnosis have been made via proper laboratory investigation, this can also help us institute effective therapy. And also, this analysis can help us to determine the functionalities of various organs in the body. It can also be employed as a checklist for patients that has been previously diagnosed with any abnormalities with any of the blood cells. And hematology and biochemical analysis can as well form part of the geriatric profile used in examining old patients. So this is precludes to enable us understand the essence for which these analyses are very vital in the practice of small animal. So when all of this have been established, and for a lab to be able to carry out any of this analysis, there are basic tools that must be provided. And that will take us to the next slide. That for you to, please, next slide, please. For you to have or to conduct hematology or biochemical analysis, there are basic tools that are minimum. So the next slide, I'll take them one after the other. Hematocrit centrifuge, which is used for determination of PCV, and the one on the right side is the hematocrit reader, that after the blood sample has been centrifuged, then it is read with the aid of hematocrit reader. Next slide, please. So these are tools that are basic for any lab that will be conducting hematology analysis. The left image is an array of capillary tubes that is also used to determine PCV with the aid of the previous slides shown, that is for hematocrit and hematocrit centrifuge and, you know, the hematocrit reader. So the one in the middle is refractometer. This can serve dual purpose for determination of protein concentration and urine specific gravity. It's a vital tool that cannot be underestimated in hematology and biochemical laboratory. Then the right panel shows the reading from the refractometer, whereby you can read both the protein concentration if blood sample is being considered, or urine specific gravity if urine has been the sample of choice. Next slide, please. Yes, the left panel shows hemocytometer. This is a valuable tool as well that is used to determine the total blood cell count for all the 3 types of blood cells: the white blood cells, the red blood cells, and thrombocytes. This new improved Newbar chamber or hemocytometer can be used to determine the total number of these cells, but the method is referred to as the manual method. However, if a practice or a laboratory does not make use of the manual method, the right channel is showing auto hemo analyzer. It can be used to determine all the components of complete blood count, from the total blood cells, the white blood cell, the red blood cell, the platelets, the erythrocyte indices, and as well as other parts of the blood parameters. The next slide, please. Yes, the microscope is also a vital tool that must be present for any meaningful investigation to be made. And glass slides as well as cover slips, they are also useful in the use of making thin smell or thick smell, depends on the type of analysis that one wants to carry out. The next slide, please. Reagents and other tools. Yes, when you have the physical tools, the reagents are also as important as the equipment. So part of the reagents that are vital to analysis are WBC diluting fluid, which is the tox solution that is made up of the glacial acetic acid and any of the bleach staining dye. Then the RBC diluting fluid also, you can use the normal saline, but the best is to use the MS solution that contains the sodium sulfate, sodium chloride, and mercury chloride, which helps to preserve the integrity of the red blood cell. There's also platelet diluting fluid, that is ammonium oxalate. Then the stains that are vital, the Romanowski stains, the Giemsa, the Wright, the Leishman, and Diff Quick, distilled water, as well as water distiller, blood sample, sample bottle, percutaneous tubes, needles, and all of this, as mentioned, they are the minimal equipment that any lab whatsoever that is into hematological or biochemical tests or analysis must have before any meaningful results can be obtained. So next slide, please. Yes, when all of this has been established and the analysis have been done, the next is to interpret. And like I said, there is no meaningful diagnosis without laboratory investigation. And what's the essence of the laboratory investigation without meaningful interpretation? In spite of that, these factors are very important in making a sensible interpretation of our lab results. I mentioned it in the previous presentation, the pre-analytical, analytical, and post-analytical. For pre-analytical, it has to do with the period in which the patient is brought to the clinic. How was the patient brought to the clinic? How was the vital parameters, the vital parameters, how were they taken? How was the blood obtained? How was the animal restrained? All of those things, they culminate into what pre-analytical factors are. Then for the analytical phase, it is the period in which the samples is being analyzed before the final result. So, and a lot of factors such as the diluting fluid, the diluting factor, the technical know-how, the type of the machine used, and what have you. Then post-analytical, especially when the units in the reference value differ from what the interpreter is using. So all of these things must be taken into cognizance before meaningful interpretation can be achieved. Next slide, please. Next slide. So why basic hemogram abnormalities? When the results of laboratory investigation are available for hematology and for clinical chemistry, then there are basic abnormalities associated with hematology. Since we have 3 types of blood cells, the erythrocyte, the leukogram, and the trophogram. So the erythrogram helps us to evaluate the activities of the erythrocyte, including its indices, such as the PCV, the hemoglobin, the MCV, MCHC, and MCH. So the increase or decrease in these values are pointer to what is happening within the erythrocyte. Apart from the increase or decrease, the blood cell can also be examined via the microscope to look at the shape, the size, and other inclusion bodies that may be associated with erythrocytes. For leukogram, basically there could also be increase or decrease whereby you have leukocytosis or leukopenia. And the leukocytosis or leukopenia could be due to any of the differential white blood cells, that is the neutrophil, eosinophil, monocyte, or lymphocyte. Also, with the aid of microscope, you can as well examine if there are degenerative conditions associated with these cells. These two can be observed. Therefore, thrombogram, which is the platelets, basically also you can either have increase or decrease in the values. Then the increase will be thrombocytosis, while decrease will be thrombocytopenia. And also PDW, that's the platelets distribution width, can also be determined so as to know the size of the platelets, if there are variations or the sizes are intact. So basically, the abnormalities associated with hemogram are the three listed on this slide. The next slide, please. So for clinical chemistry, the parameters basically also can either be increased or decreased, but the history and the clinical complaints will guide us to what one should be looking out for. For electrolytes, talk about the sodium, the chloride, the potassium. Then for the proteins, is it the albumin, globulin, fibrinogen? Is there increase or decrease, or it is normal? If it is increased, what has brought about the increase? And if it's otherwise, what is responsible for these changes? And blood gases, the oxygen, the CO2, that can also help us to determine, is it either respiratory acidosis or respiratory alkalosis, or metabolic acidosis or metabolic alkalosis. And for the enzymology, liver enzymology, you want to determine if there is any alteration in the functionalities of the liver. For these enzymes are supposed to be resident within the liver. We have the induced enzymes, we have the cytosolic enzymes. So the cytosolic enzymes, whenever there is hepatocellular damage, they find their ways into the bloodstream and making their value to be increased. And for induced enzyme, it is not primarily resident within the liver hepatocytes. There are other tissues or organs. For instance, bone marrow also contribute to the production of ALP, which is an induced enzyme. So basically, increase or decrease in these enzymes too can also help us to determine if there is any abnormality associated with the liver. Apart from using enzymes, there are other function tests that can be used to determine liver functionality. We have direct and indirect, apart from bilirubin, that can also be used as an independent parameters. Direct, you talk about the bile acid and the ammonia. And for the indirect liver function test, we talk about the glucose, albumin, cholesterol, prothrombin time, or partial thromboplastin time. So any of these can also be used to determine the functionality of the liver. And as for the kidney, basically you have the BUN and creatinine that are almost exclusively excreted by the kidney. So their increase in blood or in circulation tells about the happenings within the body system of the animal. And in this case too, there could also be pre-renal, renal or post-renal azotemia due to the increase in the concentration of these nitrogenous compounds in the blood. And apart from the organ function test, urinalysis can also be employed to ascertain what is going on within the body system of a patient, apart from using the blood samples. And urinalysis is not only about for kidney activities alone, but it can also give information about the rest of the body system. The next slide, please. So when all of this have been made available and there is need to interpret clinical pathology data, there are basic principles that must be adhered to in order to achieve a meaningful and concrete laboratory data interpretation. One is to use complete sentence, and it should be grammatical. Using complete sentence simply means that when it is observed that there is anemia, you don't just write anemia, but make it a sentence. Oh, the patient is anemic. There is mild, moderate, or whatever category of the anemia. So use a complete sentence. And the next point is to be organized in your approach. We have 3 types of blood cells, majorly: the erythrocytes, the leukocytes, and the thrombocytes. So you have to be organized in your approach. Identify first the abnormalities associated with the erythrocytes, then followed by leukocytes, followed by thrombocytes. Don't lump everything together. You are talking about anemia, and the next point you are talking about leukocytosis. No, be done with a particular cell or group of cells that are related before you move to the next cells or parameters. So that's what is meant by being organized in one's approach. Also, appropriate technical terms should be used where necessary. Like I used to tell my students that anyone that writes there is low PCV, for me, I'll mark it wrong, even though the result says there is low PCV. But as a professional, what does low PCV mean? It means there is anemia. So it is better to write those anemia, then that's when you'll be able to quantify the level of anemia. But writing there is low PCV, there is low blood glucose level. Why not hypoglycemia? That makes it more, audible and more logical. So then the next one is do not neglect to point out all abnormalities. Every abnormality is important. It could be the one that you want to neglect that is responsible for the diagnosis you are looking for. So every abnormalities observed must be stated. The next slide, please. Yes, do all calculations that are vital to your interpretation. This is common with the lab, whereby they make use of manual method of blood analysis, like the use of centrifuge to determine your PCV. You use the hemocytometer to determine the total white blood cell counts, total red blood cell counts, total platelet cell counts. Then, but for those using autoimmune analyzer, the machine will do all of these things for you. But for those using manual, after determining the total blood cell counts, there are erythrocyte indices, the MCV, mean corpuscular volume, that is, you have to calculate the value. MCH, you have to calculate the value. MCH, you have to calculate the value from the standard formula that is available to the laboratory. Then sometimes when you have more than 5 nucleated RBC, it has altered the value of the total white blood cell. So there is something we call corrected WBC count. So that you have to calculate that from the total WBC count, because the number of nucleated RBC has added to the number of the total white blood cell, because it was considered as a nucleated cell, but it is not a WBC, but rather an RBC. So do not merely list all possible causes of identified abnormal results as reference. There, for instance, there is neutrophilia that's increased in the absolute value of neutrophil. And when you know how to write what could be, you want to infer as to what could be the cause of that neutrophilia. There's no point writing all the possible causes of neutrophilia, but write the ones that are associated based on the history given and the clinical observation of that patient. So when there is no need to mention something that is not relevant. So you have to look at the history, consider the clinical presentation, the vital parameters, then you'll be able to streamline what is needed with respect to your inference. So you don't just list all the possible causes of an abnormalities, but the ones that are particular to the case in question. And also your diagnosis must be consistent with the findings. What this means is that you have various evidences before you. You have various evidences before you that this patient is suffering from, for instance, renal failure. But there is an analyte, ALP, that is slightly increased. But because of that slight increase in ALP, alkaline phosphatase, then you are now basing your diagnosis on that, saying, oh, there is cholestasis due to, the increase in ALP, while leaving the other parameters that are pointing to renal failure. So diagnosis must be consistent with the major findings, not just ordinary finding. And with all this, if they are considered, it will help to make a meaningful laboratory interpretation. Then we'll look at a case study, and some of these points will be, explained as we look through the case study together. The next slide, please. Next slide. Yes. A 5-year-old female German Shepherd dog was presented to the small animal units of the veterinary teaching hospital, University of Ilorin, with the complaint of reduced appetite, vomiting, and passing out of brown urine. So the clinician felt there was need to, take blood samples to be able to arrive at a definitive diagnosis. With this, a lot of conditions can present with reduced appetite, vomiting, and passing out of blood urine. So we'll be looking at the results at the next slide. Yes, this is the haematology results. The RBC, the value from the result is 4.85, which is lower than the reference interval. The hemoglobin is as well lower than the reference interval. The PCV is also low. The MCH and MCV, they are also below the normal reference interval. The PCV is what is primarily considered for either if the animal is anemic or not. So from what we have here, the PCV is 32. And the reference interval, that is the normal range, is between 37 and 55. So it means that the animal is anemic, and it is supported by the decreased value of the RBC counts and the hemoglobin counts. Then the MCV and MCHC, or MCH as the case may be, in another hemogram. So the MCV is used to determine the size of the RBC, while MCH is used to determine the concentration of the hemoglobin. So they are introduced to help classify the morphological classification of anemia. So when the MCV is low, that is below the normal reference value, you talk about smaller size of the RBC, and that will be referred to as microcytes. Then if it is normal, if it is within the reference interval, then it is referred to as normal sites. And if it is bigger than the upper value of the reference interval, then it will be referred to as macrocytes. And when you now want to, then for FCHC, in the same vein, practically, we may not have hyper chronicity, because the RBC already concentrate the highest number, but in the case of hemolysis, we could have something like that. But majorly or basically, what we have is hypochronicity or normochronicity with respect to the concentration of the hemoglobin in the cell. So in this particular case now, the value of MCV is 68, which is within the reference interval of 60 to 70. So it means the cell size is normal. So it is normal size. And because we want to use the term to classify the type of anemia we have, so it becomes normocytic. The MCHC is 32 as well. It is also within the reference interval. So it is also normochromic. So what we have in this case is normocytic, normochromic, normochromic. And because we have anemia that is shown with the reduced value of PCV. So what we have now is normocytic, normochromic anemia. Then the extent of reduction in the value of PCV can help us, aid us to know if the anemia is mild, moderate, or severe. But with what we have here is mild. So we have mild normocytic, normochromic anemia. That is because I said we have to be organized in our approach. We have done business with the erythrocytes and its indices. So the next on the panel is platelets, which is also severely lower than the reference interval. So for platelets, there is thrombocytopenia because the value of platelets in the result is severely lower than the reference interval. Then we now look at the WBC, which is the total WBC counts. So we have 42, which is also lower than the reference interval 6 to 17. Then what we have there is leukopenia, because it is wherever you hear penia, it means it is lower than the normal. Then cytosis or philia means it is higher than the upper part of the reference interval. So for this, there is leukopenia. Then the leukopenia due to, because the WBC is talking about the total WBC, then each one or more of the differentials must be responsible for that increase or decrease in the total WBC. So if you now look at what we have here, the neutrophil is also lower than the, the reference interval. So the leukopenia could be due to neutropenia. Then we now look at the lymphocytes, which is also lower than the reference interval. So it will now also be lymphopenia. So that is, there is leukopenia due to neutropenia and lymphopenia. And I think the rest parameters are within reference interval. So we now have normocytic, normochromic anemia, thrombocytopenia, leukopenia due to neutropenia and lymphopenia. So we now look, that is for the hematology. Let's now go to the serum chemistry. Then before we now arrange everything to aid us with diagnosis. So the total protein is slightly higher than the upper value of the reference interval. So it means there is hyperproteinemia. Because then for albumin, it is lower than the reference interval. So what we have here is hypoalbuminemia. Therefore, globulin, which is higher than the reference interval, we have hyperglobulinemia. So it means that the hyperproteinemia that we have here is as a result of hyperglobulinemia. Then the urea and creatinine, they are the nitrogenous compounds that are used for azotemia. So both are increased. In that case, we have azotemia. So the next is now to determine if the azotemia that we have is either pre-renal, renal, or post-renal. So from the history, there was nothing that indicated that the animal was hydrated. If there was nothing of such, we can be thinking of renal azotemia. Then the onus now is to do other confirmatory tests to support the renal azotemia, at least to look at the urinalysis and look at the components of the urine to see if urine is, the kidney is being able to concentrate or dilute urine effectively. So let's now go back to the haematology so that we will now use what we have, the normocytic normochromic anemia, the thrombocytopenia, the leukopenia due to neutropenia and lymphopenia. With this, it is apparent that what we have is pancytopenia because all the blood cells are decreased. They are below the normal reference interval. So we now look at what are the conditions that can bring about pancytopenia. We have quite a number of them, but once this is observed, this smear is needed to be made so as to look at the blood cells, the morphology of the blood cells, and what it contains. Fortunately, in this particular case, Babesia canis was found. So, and if you now look at the hemogram, the findings of this hemogram, they are in support of Babesia canis, or the case of babesiosis. So apart from this, Ehrlichia may also present itself this way, but because Ehrlichia was not found, but Babesia was found. So if this test was not done and the smear was not made, we would not have been able to perhaps say to identify this organism, because UTI could also present itself with the history given and with the brown urine in the brownish urine compared to the azotemia, then there is need for us to further check out for the functionality of the kidney to see if the kidney has been severely affected or not. But then the albumin, there is a negative. Please go to the serum chemistry. There is total protein that is shown as hyperproteinemia, then with characterized by hypoalbuminemia and hyperglobulinemia. This type of results, it's an indication of an inflammatory process. Albumin is a negative acute phase protein, so it decreases with inflammation. But for globulin, when there's inflammation, there's increase because the immune cells are being excited to, they are being produced so as to, get to the site of inflammatory process. So in essence, the hyperproteinemia that is due to hyperglobulinemia can be associated to inflammatory reaction, and the azotemia can be traced to the renal origin. And these panels, the normocytic normochromic anemia is an anemia of, it can be an anemia of acute or chronic condition. But acute is in the case of acute blood loss, whereby the body has not responded, the bone marrow has not responded to regeneration. But more often than not, it is seen in chronic condition. So it tells us that this babesiosis is of chronic type, and there is an ongoing inflammation due to the hyperglobulinemia and hypoalbuminemia, and the renal azotemia can be further diagnosed with the case of urinalysis. What saved us from this case is that the hemoparasitic screening has revealed that there is Babesia canis, and I don't think there is any further test needed to confirm the presence of Babesia once it has been found within the erythrocytes with their piriform shape for Babesia canis and other shapes for the other types of Babesia. So in essence, the carrying out this blood work has given us a clue as to what is going on within the body of an animal. It has helped us to classify the type of anemia. It has also been able to tell us how long the condition has been, and the identification of Babesia canis has also helped us to limit our diagnosis or to confirm our diagnosis to babesiosis, because the clinical the laboratory findings, they are inconsistent with what is associated with babesiosis in dog. So, next slide. The take-home message is that the adoption of evidence and scientific-based approach in disease diagnosis gives credence to the standard of practice. Thank you for listening. And I'll be here to entertain any question, comments, and observations. Thank you.
Thank you so much, Dr. Abdul Latif Ajadi, for that presentation. I have observed that we are well over 86, about 86 in attendance. At a point, we got to 88. I have also observed that there are some people that are here on this platform that were not there when we had a similar lecture some weeks back, which means the interest is being developed, and people are passing on the message. We have to all be on this, for us to succeed, both as individual practitioners and as a country. We will entertain a few questions and concerns and comments, but let them be very, very brief. Everybody, others that have, everybody that has, as much as we can take, the rest can put up their questions and comments on the chat box, and we'll harvest all of them. I've already seen like 2 or 3 of such, and we'll thank those that have done that. Before we start with the questions, I can see a hand up, Mohammed, I think that's Mohammed Bashir. Before we start with the questions and comments, there is one of our colleagues here whom I want to personally and especially recognized in our midst. We have Dr. Francis Kakulu. I hope I got it right. And Kakulu is the lab manager of Zoetis, South, SSA, Sub-Saharan Africa. And he's a very important mentee on our COTOG program. We hope to benefit from his wealth of experience. And let me just mention it here that we cannot succeed in what we plan to do if we don't engage the laboratories, even at basic levels, the VTHs and the private practitioners level, and we need collaborators like Zoetis to help us in achieving this. So, Dr. Kakulu, I don't know whether you have anything to say before we have our questions, just to give you that benefit of, if I may call it that, importance. Dr. Kakulu, Francis.
Thank you so much, and happy to join this very good session, Tezena. And thank you so much for the recognition. I work with Zoetis as the Regional Technical Manager for Diagnostics. I don't know much time was meant to have, but I would have gone through our range as well to support the presentation of Dr. Ajadi. And thank you really so much, Dr. Ajadi, for that well explicit and elaborate presentation that you have taken us through. So with Zoetis in brief, I wouldn't want to take really much of your time, and I wanted to share just one slide. If you can allow me, Dr. Ezena, I will not share everything that I had, but I will leave us with this last slide that I had, and probably it will shed more light in what we want to support the region of Sub-Saharan Africa in terms of training. And this is the opportunity that we bring on board, especially in the area of diagnostics, in the area of companion animals, but also in other areas that may be of interest for you. As a company, Zoetis, we do as well manufacture diagnostic solutions, and some of which could potentially support the diagnosis, just as Dr. Ajadi was mentioning there, really to support the manual process, because in the genesis of lab, the manual processes have been efficient, and but we have come up with extensive diagnostic solutions that could really be of much interest for the practitioners, and these include the hematology analyzers, which are really efficient with over 17 parameters that you can do and support the diagnosis that we have just listened, the well thought message that Dr. Jadi was passing on. And the key also in that, in line with automation, is the uniqueness to have a 5-part differential and a 3-part differential. That is really also important for anyone who wants to venture into full automation. it's important that you notice what you want. You want a 3-part or you want a 5-part, because a 5-part will give that all information that Dr. Jadi just shared there on the screen, that result there, which has all the white blood cells being listed. That's what makes it a 5-part. And then a 3-part will just only give lymphocytes, monocytes, and granulocytes. Now you had Dr. Jadi really breaking them down in that report. Now, assuming you do not have a 5-part and you have a 3-part, so it's important that you consider that when you are looking for a service provider for that full automation, but also as well the extensive test range. Now, we bring to you a solution of an hematology analyzer that tests about 17 parameters, no, 22 parameters, but over 17 species that you can be able to test. So it's important that you have this in mind to support your practice when you're doing that. But also, probably maybe to add, to supplement on what Dr. Jadi mentioned, is when you have a report that is able also to give you graphical representation, and those are the histograms, they aid in full interpretation of what you could come up with as a case. So our reports also give that. The hematology analyzers give you a well-elaborated histogram report that is able to help you. But key important also to note is that, and that's why I liked what Dr. Jadi mentioned, that when they did the blood smear, they were able to see Babesio's. So the gold standard for hematology to support all this diagnosis is important to know that it's a blood smear. So it comes in there to support your workout and to be able to confirm all those pictures that he was talking about, the nomocytic, the nomochromic, cases of hypochromasia or hypochromic anemia. So it's important that you think about that and also have a well-made blood smear coming up there. Now, when it comes to blood chemistry, we also have a solution called VS2 analyzer. And it also gives you an opportunity to use our technology, which is based on rotor technology. It uses a rotor, but works on the principle of absorbance to be able to give you the report there within 12 minutes. You have a result in your clinic, because the importance of diagnosis also is to be able to have a quick test and also a quick decision that you are able now to help this patient, you're able to help this client of yours, and a happy customer, indeed, he makes you a happy clinician or a comfortable clinician, if I would say it that way. So we also have that technology and an extensive test of parameters that we do support right there to be able to help you. We have others that come in, the urine analyzer, a portable handheld urine analyzer. When Dr. Jadi was mentioning all this that is able to help you come up with a diagnosis, we have fully automated urine analyzers where you use a dipstick and it gives you a quantitative result, where you don't have to guess whether it's plus, whether it's stress, whether it's what. It gives you quantitative results, and all these support the clinical decision that you want to come up with. All these parameters that he was mentioning in the case presentation, you are able to get them. And of course, other analyzers that you can do in pre-anesthetic cases, you are able to get these analyzers, even in your country, Nigeria. Thank you so much, Dr. Zona. I had a full presentation, but I know because of time, we may not be able to go through it, but I would implore you to just scan this and be able, within your free time, to go through these learning sessions. Thanks again, and happy to connect. Thank you.
Yeah, thank you so much, Dr. Francis, for that. And I think that has added more value to what my brother, Dr. Jadi, did for us earlier. As I said, I've seen some comments on the chat box, but we'll just take some other one. Maybe how many are we going to take? 2 from the audience, from the participants here. already there is a hand up. That is Dr. Muhammad Bashir. Sorry, I kept you waiting for so long. I'm sure you could understand why we had to take something from Dr. Francis. So you can take them together, what Dr. Ajadi did and what Dr. Francis did. So, Bashir, you are on.
Okay, thank you, sir. And
Thank
I
you.
want to
Just very direct. Yeah.
okay, and the presenters. Please, I have a question about from the first presenter. I want to know the relationship between renal azotemia and the hemolytic parasites that are based on his presentation, with making a reference to a parasite like Babesia and other hemoparasites. Thank you, sir.
Dr. Ajadi, did you get what his question is concerned?
I didn't get it clearly. I don't know if you can help me with.
Maybe you can repeat it. Dr. Bashir, can you just repeat it? Because I didn't get it too from here. Can you unmute yourself and repeat your concern, okay?
I don't know that it was not English. I said, please, I want to know the relationship between renal azotemia and the hemolytic parasite, making a reference with parasites like Babesia that you made mention. Thank you.
Did you get it now?
The relationship between azotemia and hemolytic parasite, example, Babesia.
Okay, relationship between azotemia and hemolytic parasites.
Yes, sir. Thank you, sir.
Okay.
Yes, thank you.
Do you want to take all the questions?
Okay, let me take another one. Yes.
Is there any other question? Let the person so indicate by raising of hands. If there is none, then we'll just go straight for this, to this, and then okay, there is yeah, that is still Mohammed Bashir. So Dr. Ajadi, can you address that? Thank you.
Yes. The relationship between azotemia and hemolytic Babesia is not as if there is direct relationship, but the effect of blood cells being lysed, because when you have an infectious disease of this nature, for instance, the azotemia, if it is of renal origin, so because of the availability of the hemoglobin that has been destroyed, and as it's getting, there will be reduction of the blood volume to the glomerulus, and when the kidney does not have enough, blood to filter, it becomes it affects the nephrons, especially the glomerular tubules. So as the thing becomes chronic, the effect will be shown. But if it is acute, that may not be seen, because most of the times, what we have, the type of anemia is macrocytic hypochromic, whereby the blood is being regenerated. But in this case, that has become chronic. So the relationship could be as a result of the chronicity associated with this condition. So, but directly, there may not be any relationship between the hemolytic parasites and azotemia that is of renal origin. But if there have been dehydration, which has resulted to pre-renal azotemia, so that's another relationship between the hemoparasites and azotemia.
Yeah, thank you very much, Dr. Jadi. There is a question or an opinion by Udeshuku from Udeshuku in the chat box. I think it's obvious that the Babesia canis is probably not the cause of the anemia, considering the class of anemia. Considering the class of the anemia, pyroplasma can cause especially Babesia. That is one. Then from Dr. Ohore, pre-renal azotemia is associated with hyperalbuminemia. Hyperalbuminemia evidences an immunological
I read
reaction.
that. Can I quickly respond to that, sir?
So
yes,
yeah, you
Dr.
can respond to
Orere
that.
is my teacher, and I think he was only trying to answer what the previous commenter wrote.
Okay.
The commenter was saying it should be pre-renal azotemia. So he was not saying pre-renal azotemia will be associated with hyperalbuminemia. And what we have here is hypoalbuminemia. And that can also be resulted from renal loss. It is also possible. The disease or condition of the renal can also bring about hypoalbuminemia. And if we are talking about pre-renal azotemia, then we should have either normal albumin or hyperalbuminemia to support the pre-renal azotemia. But what we have here is renal azotemia, and it is also evidence with what was reported in the history that there was brown urine. So meaning that the kidney is also deficient in its functionality.
Okay, so the there is an opinion or a question that was dropped in the chat box from just hold on. From Sandra, Dr. Sandra Benson. I think the azotemia was pre-renal due to dehydration because there was history of vomiting. And that was followed by someone else, Dr. Amina Salihu. It could also be pre-renal due to blood loss through anemia. That is decreased blood flow to the kidneys. What do you have to say to this, Dr.
Yes,
Ajadi?
it is in line with what I said earlier. And the possibility is that there could be pre-renal and renal azotemia occurring concurrently. It is very possible. Yes, what they have said are very correct. There could be pre-renal azotemia, but what we have in line with these findings, there is pre-renal azotemia. And as they have rightly said, there could also be pre-renal azotemia. But the fact that the renal azotemia comes first, but there could be a concurrent pre-renal azotemia. I agree with them, fine, there could be pre-renal, but there is renal azotemia. But at least like I said, the evidence is that it is renal is more than it is pre-renal, but there is possibility of concurrent pre-renal and renal azotemia. It is very possible.
Thank you so much, Dr. Wakonobi, for that well-moderated session. I don't want to be taking too much of our time. I'd like to thank Dr. Ajadi for giving us more insight on diagnosis. So I'll be calling on Dr. Bala Mohammed to come and wrap up this beautiful session and also give us any other announcements he has for us. Thank you so much.
Thank you so very much, Dr. Awa, Dr. Nwakonobi, and all our participants for making it today, to today's yet another session. And I'm quite impressed that the real philosophy of the connecting town to Ghana is now coming to be very clear to all. We had Dr. Francis, who is the sub-Saharan manager about this equipment from Zoetis, making presentation. We've also had our teacher, our mentor, Dr. Abdulatif Ajadi, who also made a very invaluable contribution as to how we can make the best out of interpretation of haematology and biochemistry testing results. We are desirous of making sure that every practice in Nigeria will have to have a piece of this equipment in terms of how we move the standard of practice forward. And I'm also happy that we've gotten a lot of our colleagues from the teaching hospital participating. I saw my senior brother, Professor Anaga, who is the director of veterinary teaching hospital, University of Nigeria in Nsukka, participating. And what we seek to do is to see in the nearest future how all of these teaching hospitals will be equipped with this standard equipment, but also give the student vets the opportunity to use this equipment and understand the level of the importance of this equipment in our day-to-day activities. So I'd like to thank all of you for making it to today's presentation, and specifically to thank Dr. Ajadi for his time and all that he is doing, even in the behind the scene, to making sure that our mentees get the right skills in practice. I would also want to thank Dr. Francis Kulele, the Sub-Saharan Africa, for these contributions that he has made today. They've also promised that they are going to be making a more elaborate presentation in the nearest future. We have very exciting and interesting topics in April, specifically 2nd of April, for some more exciting topics, and you will like it. We want to bring some of the insight and opportunities to you by some of our colleagues abroad, and we will be announcing the topics in due course. On behalf of my colleagues here in the Connecting Town to Gown, on behalf of all of you, I would like to thank you for making it a success today again. And we've also gotten some gifts from some of our partners in China who will be supplying some of these things. We will look at how we are going to share it, because we have, I think, about 200 pieces of this gift. And it's a flash drive with different equipment that you will use and contact and where you can also get your reagents and some of the portable equipment that you could use in haematology analysis, but also biochemical analysis in small and companion animals, and like with also zoetis. We've saved all your contact, and we'll see how we get to pass some of this gift across to all of you. Until then, thank you so very much for making it a date with us. Good afternoon.
Thank you, everyone.